So next question states that which nerve does not contribute to the innervation around the elbow joint? So the answer would be posterior anterosseous nerve. As we know that the posterior anterosseous nerve is a motor branch from the radial nerve. So let us take some time to understand about all the innervation of the upper lip. So starting from the hand, we know that this front area of 3.5 digits is supplied by the median nerve, and this area is supplied by the ulnar nerve, and this very small area on the anterior aspect is supplied by the radial nerve. However, similarly, on the posterior aspect of the hand, 3.5 lateral digits are supplied by the radial, whereas ulnar nerve is supplying anterior as well as posteriorly, medially 1.5 digit area. In the forearm, we have the medial cutaneous nerve of the forearm, which is a direct branch from the medial cord of the brachial plexus. Then we have the lateral cutaneous nerve of forearm, which is a branch from the musculocutaneous nerve. Then we have the medial cutaneous nerve of the arm, which is again a direct branch from the medial cord. Now, this area of the arm is supplied by the intercostobrachial nerve. Now, this area over the deltoid is divided into upper lateral and lower lateral cutaneous nerves, out of which the upper lateral cutaneous nerve of the arm is the branch from the axillary nerve. This is very important to know. And this area of the very superior and lateral aspect is supplied by the supraclavicular nerve. So, this is all about the cutaneous innervation of the upper limb, out of which posterior trochleus nerve is a motor branch and it does not give any innervation around the elbow joint. So next up we have a 73-year-old lady who had a fracture at the surgical neck of the humerus. There was difficulty in reducing the fracture and a vessel lying posterior to the surgical neck got injured. Which vessel is most likely to be? So as we know that around the surgical neck we have two very important structures. One is the posterior circumflex femoral artery and second is the axillary nerve. So these are the two structures which can be asked in the form of a surgical scenario, or it can be asked in a plain scenario as it has been asked in this question. So next question states that through which structure does the axillary nerve passes? So we have the quadrangular space. So as we have discussed previously that the quadrangular space is bounded superiorly by teres minor, inferiorly by teres major, medially by the long head of the tricep, and laterally by the surgical neck of the humerus. So in relationship to the axillary nerve, we have two important landmarks, the surgical neck of the humerus and so is the quadrangular space. So both of these structures are in close association with the axillary nerve, and regarding the vessel, that is the posterior circumflex humerus vessel. So next up we have a 43-year-old man who got stabbed outside a nightclub. He got a transection of the medial nerve as it leaves the brachial plexus. So this is a kind of a higher medial nerve injury as it is leaving from this area. So we can have in our mind that almost all the motor and sensory innervation of the medial nerve are going to be absent. So the question is asking that which feature is least likely to occur. So they have asked you that out of the options, which is less likely to be present, rest of the features will be present. So here the answer would be complete loss of the wrist flexion. So as we know that in the flexors of the forearm, only two muscles are supplied by the ulnar nerve, that is the FCU and the medial half of the flexor digitorum profundus. Now, with the absence of the medial nerve, these two muscles will be present. Now, out of these, we need to know that for the flexion of the wrist, we have two muscles. We have the flexor carpi radialis, which is supplied by the median nerve, which will be absent. But flexor carpi ulnaris will be functioning properly because of the presence of the ulnar nerve. So that is the concept that you need to understand in this question. So next up we have the transection of the radial nerve at the level of the axilla will result in all except So as we know that radial nerve is, so in this question, it has stated that it is going to be a high level of radial nerve injury. Now, second thing is that radial nerve is associated with extension of all the muscles, that is around the elbow joint as well as around the wrist joint. So it will come in our mind that all the extension will be lost. So what they have asked here, that in this high radial nerve injury will result in all except, so the answer would be loss of the extension at the interphalangeal joint. So we will think that which of the extra muscles are present which are also performing extension at the interphalangeal joint. So the answer is lumbrical. So in the absence of the radial nerve, lumbricals, out of which the radial two lumbricals are being supplied by the median nerve, and the medial tube being supplied by the ulnar nerve will be functioning normally, and these lumbricals are able to produce extension at the interphalangeal joint. So you should also be very much aware about the exceptions because they are very frequently tested in the exam. So next up we have a 44-year-old lady who had mastectomy and axillary node clearance. Post-operatively, a patch of anesthesia of the axillary skin was found, which applies an underarm deodorant. When the patient applied an underarm deodorant, they felt that they cannot appreciate the senses. So which nerve has most likely been affected? I have explained this part before. So the nerve would be intercostobrachial nerve. So this medial area of the forearm, in addition to this axillary area, is being supplied by this nerve, and this is frequently injured in the axillary node clearance or in mastectomy. In addition to this, this area also contains long thoracic nerve, which is supplying serratus anterior, which can produce springing of the scapula, and so does there could be damage to the thoracodorsal nerve and vessel as well. Now this is again a diagram to get you a better concept. So I have found this diagram in which all the vessels and nerve which can get damaged are present. So they can ask you about the vessel, and the vessel would be the thoracoacromial artery, which is a branch from the second part of the axillary artery. And then we have the intercostobrachial nerve, the thoracodorsal nerve and vessel, and the long thoracic nerve. So this area is very important. It can be tested in various ways. So next up we have that with respect to the basilic vein, which statement is false? Like which statement is not correct? Rest of the options will be correct. So the false option will be its deep anatomical location makes it unsuitable for AV fistula. So we know that these superficial veins, which is the basilic as well as the cephalic vein, they are present quite superficial. So it is quite wrong about this because they are the sites which are actually used for the AV fistula formation, and one of the reasons is that they are present in the superficial fascia and they are fixed and they are quite easily available. That is why they are actually used for this procedure. So next up we have a 23-year-old man who had a fall and slip outside a nightclub. A shard of glass penetrates the skin at the level of medial epicondyle, which sequelae is least likely to occur. So we know that with medial epicondyle, there could be injury of the ulnar nerve. So we have to think that there could be features related to the ulnar nerve. Now, which sequelae is least likely to occur? Now, here is a concept known as the ulnar paradox. So, ulnar paradox is a very important concept and it is very frequently tested in the MRCS Part A. So, let me explain this with this diagram. So, in ulnar paradox, the concept is that we can divide the ulnar nerve degree into high and low level. Now what happens is in the low level injury, like over here, that has not been described in this MCQ, that is around the flexor retinaculum. What happens is that ulnar nerve has already supplied flexor carpi ulnaris and the medial half of the flexor digitorum profundus. So when the patient will be asked to make a fist, he will be able to flex the distal interphalangeal joint towards the palm of the hand. So there will be more plowing. However, if there is going to be a high nerve injury that is around the medial epicondyle or in this mid area of the forearm, in this area, these muscles will have no supply. They will have a complete loss of function. So when now the patient will be asked to flex or make a fist, the patient will be unable to form so. So the concept says that the higher the injury, the less the clawing, the distal the injury, the more the clawing. Now, this is called a paradox because in normal situation, you will think that whenever a nerve injury is injured at a higher level, there is going to be more pronounced clinical picture. Whereas in this, it is completely opposite. So you can take some time and read through the text. I have tried to elaborate this concept in the most simplest way as it could be. So in the distal third of the upper arm, where is the musculocutaneous nerve present? So you should be very much aware about the location and in its location, the relationship of the nerves to the specific muscles or blood vessels or other nerves. So here we can see that in the distal third of the upper arm, musculocutaneous nerve is going to be present between the bicep as well as the brachialis muscle. So we have gone through this concept previously. So you can take some time and revise all the concept related to the musculocutaneous nerve, that it is arising from the lateral cord, it is supplying the BBC muscles, and later on it becomes the lateral cutaneous nerve of the forearm, and it supplies this area. So the next question states that at the level of the wrist joint, which statement best describes the relationship of ulnar artery to the ulnar nerve? So it is very important question. It is a relationship type of question, which is one of the frequently tested area in this exam. So the answer would be that ulnar artery is related on the radial side. So try to focus on this diagram that so this is the little finger side is the medial side and thumb is the lateral side. So we can call this medial or ulnar side because in different texts you can also find written ulnar, and the lateral can also be described as the radial side. So that is an important concept. So here you could see that the most medial structure is going to be the flexor carpi tendon, then is going to be the ulnar nerve, and most lateral structure or the most radial structure is going to be the ulnar artery out of these structures. Here on this side, the most medial structure would be the radial artery. Similarly, we will have radial nerve over here, and then we will be having the flexor carpi radialis tendon as well. So next question states that a 24-year-old man falls and fractured his scaphoid bone. From which area does the scaphoid derives the majority of its blood supply? So we know that scaphoid is having its blood supply from the distal to the proximal. That is the one concept. Number two, we know that radial artery is supplying the scaphoid. Now, radial artery is dividing into dorsal as well as the polar branch. Out of these two branches, the dorsal branch is the main contributor of about 70 to 80% of blood supply of the scaphoid. Whereas the anterior or the volar branch is only responsible for 20 to 30% of its blood supply. So next question states that a 22-year-old man develops an infection in the pulp of the little finger. What is the most proximal site to which this infection can migrate? So in this question, they are testing your knowledge about the spaces of the hand and their communication. So if any infection is present in the pulp of the little finger, it will communicate with the ulnar bursa and come into the space of perona, and that is the proximal to the flexor retinaculum. And so does the infection of the thumb. However, if there is an infection in the second, third or fourth digit, they will not communicate proximally because they do not have a direct extension beforehand. So next up we have that which nerve supplies the majority of the skin on the palmar aspect of the thumb. So the answer would be the median nerve. So I have added this diagram to understand the sensory innervation of all these three nerves of the hand. So for median nerve, it is the main supply of the anterior aspect of the hand, whereas ulnar nerve has both anterior as well as posterior innervation, but on the posterior aspect, the primary nerve that you have to know is the radial nerve. Now, further, you can divide this innervation into two parts, that is the involvement of the palm and the fingers. Now, with the median nerve, we have involvement of the lateral 2 by 3rd of the palm, that is on the radial aspect or the lateral aspect, whereas the medial 1 by 3rd of the palm is supplied by the ulnar nerve. Now, in terms of the digits, for the median nerve, we have around lateral 3.5 digits, whereas for the ulnar nerve that is in the green, we have medial 1.5 digits. This is all on the anterior aspect. Now, there is a small area at the base of the thumb on the anterior aspect that is supplied by the radial nerve. It is an exception and it is frequently tested in the MCQs. Now, in addition to the anterior aspect, on the posterior aspect, the nail bed of the lateral 3.5 digits is also supplied by the median nerve. Now, talking about the posterior aspect, it is again can be divided into the dorsal aspect of the palm and the digits. Now, the lateral 2 by 3rd is supplied by the radial nerve. It is usually up till this area. And the medial 1 by 3rd on the posterior aspect is supplied by the ulnar nerve. So, ulnar nerve is supplying anterior as well as posterior aspect. Similarly, around 3 to 3.5 fingers is being supplied by the radial nerve, whereas on the posterior aspect, again 1.5 digits are being supplied by the ulnar nerve. So, this is all about the sensory innervation of the hand. So next up we have that which structure overlies the cephalic vein. We have discussed this before that the cephalic as well as the basilic vein are the most superficial structures present in the upper limb. So none of the structures are present above it. Only skin and subcutaneous tissue is present above them. Now there is an important concept that cephalic vein pierces through the clavipectoral fascia at its termination and it enters the axillary vein. So next question states that a baby is found to have a clumsy paralysis post-delivery. Which of the following is most likely to be present? So they're asking you that which of the following is the feature of clumsy paralysis. So that will be the loss of flexors of the wrist. So in clumsy paralysis, there is going to be involvement of the inferior trunk. So they can ask you the root values. C8 and T1 will be the root values which are involved. The trunks is the inferior trunk. And the nerves which are going to be affected are the median nerve as well as the ulnar nerve. So we have discussed this before as well that all the flexors are supplied by these two nerves. So flexor carpi radialis and flexor carpi ulnaris, both are going to be absent. So as a result, there is going to be complete loss of flexion of the wrist. So what could be the other features? Similarly, the sensory supply of median and ulnar nerve will also be absent in the forearm and the hand. Now, in addition to these muscles, median and ulnar nerve also supplies the lumbricals, and lumbricals are going to play an important role in this because in the absence of lumbricals, there is going to be a typical picture, that is, MP joint will have extension, and the IP joints will have flexion. So this is the picture. This is known as the claw hand, and it is because of the absence of the ulnar as well as median nerves innervation to the lumbricals. So absence of innervation to lumbrical is going to produce this picture, which will be clinically evident. In addition to these two things, there will be presence of Horner syndrome, which is because of the involvement of the T1, there is going to be three features, that is the ptosis, anhydrosis, and meiosis. So these are going to be the three features which are going to be present with Horner syndrome. Now, in addition to this, there is going to be loss of flexors of the wrist. Now, C8T1 is the nerve root which is being affected, and the most common mechanism by which it happens is delivery of the patient, and the baby gets armed in an extended position, or the baby's arm gets pulled while it is fully extended. That can result into damage to the lower roots, that is the C8 and T1, resulting into Klumpke's paralysis. So this is all about the Klumpke's paralysis. So next we have that which structure is most closely related to the axillary nerve in the quadrangular space. We have discussed this previously. That is going to be the posterior circumflex humeral vessel. So take your time and go through this area and revise the boundaries as well as the contents of this quadrangular space, triangular space, and the triangular interval. So next question states that a man sustains a laceration between the base of the little finger and the wrist. So the man had a lesion at the base of the little finger, that is going to be over here, and the wrist joint. Several weeks after the injury, there is loss of the thumb adduction power. So the concept here is that out of the thenar muscles, there is only one muscle which is supplied by the ulnar nerve, and more specifically the deep branch of the ulnar nerve. Now the concept is that ulnar nerve is present on the medial side, that is the little finger side, and it is going to divide into two branches. One is going to be the dorsal branch, and this dorsal branch is going to be the superficial branch, or known as the sensory branch. Now there is a thing that median and ulnar nerve, the sensory branch is the superficial branch, and the motor branch is named additionally as the deep branch. So deep branch is going to move from there, and it is going to curve around here, and it is going to be supplying the lumbricals and the altrocia in this area. And there is only one muscle, that is the adductor pollicis, that is being supplied by the deep branch of the ulnar nerve. So next up we have a 22-year-old man falls over and lands over a shard of glass, and it penetrates the palmar aspect or the anterior aspect of the hand, immediately lateral to the pisiform bone. So it has damaged this area, that is lateral to this part, that this is the medial aspect and this is the lateral aspect. So it has damaged this area, all right, on the lateral side. So which structure is most likely to be injured? Now, in reference to the pisiform bone, there is one tendon, that is the flexor carpi ulnaris, that is present in this area. Then the artery and nerve is the ulnar artery and ulnar nerve. We have discussed this before, that out of ulnar artery and ulnar nerve, the most medial structure is going to be the nerve, and ulnar artery is going to be lateral to the ulnar nerve. This is the one concept. The second concept over here is that in relationship to the pisiform, these are the three structures which can be tested that they can be damaged in this area. So next question states that what is the largest branch of the brachial artery? That is the profunda brachial artery, or known as the deep branch of the brachial artery. So what are the other branches? So this is the deep branch which runs through the spiral groove with the radial nerve and supplies the muscles on this aspect. And there are two other branches, that is the superior ulnar collateral and the inferior ulnar collateral, which are also given by the brachial artery. But out of these, the most important, major and the large branch is the deep brachial artery, known as the profunda brachial artery. So next up we have a 23-year-old man falls over while intoxicated, and a shard of glass transects his median nerve at the proximal border of the flexor retinaculum. So here we are having the flexor retinaculum, and median nerve is injured over here proximal to this flexor retinaculum. Now, which feature is least likely to be present? So they are testing you about the concept that the superficial branch of the median nerve, known as the palmar cutaneous branch, is given off by the median nerve proximal to the flexor retinaculum, and it passes superficial to the flexor retinaculum. So basically they are testing you your concepts in the form of a clinical scenario. So there will be not presence of the loss of sensations, because they will be spared, because it is given before flexor retinaculum and it passes superficial to that. Now, what will happen? So let's revise that as well. So median nerve being injured, there will be absence of the innervation to the lower muscles. And what are that? We have the lateral two lumbricals, opponens pollicis, abductor pollicis brevis and the flexor pollicis brevis. Now again, this is a diagram from the netters. So here you would appreciate that the palmaris longus tendon and the superficial cutaneous branch of the median nerve is passing above the flexor retinaculum, and it is given before the passage of median nerve through the carpal tunnel. So here you could also take your time and try to appreciate the concepts of the tendon in relationship to the nerve and vessels, which we have discussed previously, that establish first of all the sides, that this is the lateral side and this is the medial side. As you could see, that this is the flexor carpi ulnaris, then we have the ulnar nerve, then we have the ulnar artery. Now this is going from medial towards the lateral aspect. Similarly, here the most lateral structure will be the radial artery, and medial to that will be the tendon of flexor carpi radialis, and lateral to this, not appreciated in this diagram, will be the tendon of the brachioradialis. So this is very important concept. Try to focus on these diagrams, and you would also appreciate this palmar arch. I have explained this before. You can pause the video and try to appreciate the relationship of the vessels and to other structures in this area. So next up we have a 21-year-old man who got stabbed in the cubital fossa. At operation, the surgeon dissects down onto the brachial artery. A nerve is present medially. We have discussed this previously, and that is going to be the median nerve. So we have discussed that median nerve is present lateral, then it comes anterior, and then in the most distal aspect, it is present most medial to the brachial artery. So a 23-year-old man who got involved in a fight had a laceration to the right arm, and he developed loss of the extension of the fingers of the right hand. We know that all the extension is being supplied by only one nerve, that is the radial nerve. Radial nerve is going to supply triceps in the arm region, and all the extensors which you could appreciate from this, you can name them and revise them. They're all being supplied by the radial nerve. So next is, which muscle is not innervated by the deep branch of the ulnar nerve? So they can give you all of these options. So we have to select the option which is being supplied by the median nerve. So they can give you abductor pollicis brevis, flexor pollicis brevis, or opponens pollicis. So here we had the opponens pollicis. So if you have a strong grip on this diagram, I believe you will not have any problem in answering these questions, which are quite difficult to answer if you forget about the names of these muscles and their nerve supply. So next up we have a 35-year-old tennis player who developed tingling down the arm. He says that his funny bone was hit very hard by the tennis ball. There is weakness of the abduction and adduction of the extended fingers, and we know that antrochiae are the muscles which are responsible for this movement. And there are two types of antrochiae, the palmar as well as the dorsal. Now, with the palmar, we have the mnemonic, that is the pad. They are responsible for the adduction, and the dorsal ones are responsible for the dab, that is the abduction. Alright. So this movement, when affected, will be because of the loss of innervation of the antrochiae, and that is being due to damage of the ulnar nerve. Now we know that this funny bone is being appreciated as the medial epicondyle or the elbow area, because here we can revise that medial condyle has a posterior relationship with the ulnar nerve. So if there is the medial condyle, so ulnar nerve is passing posteriorly. If it gets hit or damaged in this area, then this clinical picture can be present. So 63-year-old lady had an axillary sentinel lymph node biopsy as part of their treatment for the breast cancer. Which structure is most likely to be encountered? So I did this diagram multiple times to help you with the concept of this area, as they have mentioned as well that it is a challenging question and it is frequently tested question. That is why you are seeing this again and again. So take your time and go through all these nerves which I have explained multiple times. So here we will be having intercostobrachial nerve. So next up we have a 43-year-old lady who had an axillary node clearance for carcinoma of the breast, which facial layer will be divided during the surgical approach to the axilla? So that's a surgical relevance question, and the answer would be the clavipectoral fascia. As you could appreciate, this is a cross-sectional diagram. This is the clavicle. From underneath the clavicle, two layers of fascia around the subclavius unite to form the clavipectoral fascia. Clavipectoral fascia goes down and then it divides into an anterior and a posterior part, and then it encompasses the pectoralis minor muscle, and then it unites again and becomes part of the axillary sheath. Now, we know that behind the pectoralis minor, we have the level 1, level 2, and level 3 of the axillary lymph node. That is below, behind, and above the pectoralis minor. So, if the surgeon is coming from this direction, they have to cut through this fascia to reach this area for the biopsy. So, this is all that is written over here. So as you could appreciate that this is the clavipectoral fascia. If we cut this, we will have this area exposed, that is of the pectoralis minor, and then we will cut through that or retract it to reach the different levels of lymph nodes that we require to dissect. So as you could appreciate, this is the area which will be dissected. This is a diagram to help you with the concept. So I summarized all of the areas which need to be pierced to reach the specific site. So to reach the ansa cervicalis, we have to pierce through the pretracheal fascia. To reach the sympathetic trunk, we have to pierce the parietal pleura. For reaching the axillary lymph nodes, we have the clavipectoral fascia that needs to be cut or pierced, and to reach the celiac axis, we have to pierce through the lesser omentum. So the purpose of adding for making these flowcharts is to summarize all the facts which are present in different areas, but they are related. So you can add this on your notes as well. So an 18-year-old man is stabbed in the axilla during a fight. His axillary artery gets lacerated as well as repaired. So we know that axillary artery is going to be present in this area, and it is related to the cords of the brachial plexus. So surgeon neglects to repair an associated injury to the upper trunk of the brachial plexus. That is talking about this area. So there was an injury to the upper trunk, and the surgeon, due to any reason, ignored it or neglected it. Now, which muscle is least likely to be affected, that is having impaired function? So as we know that the superior trunk is going to supply the musculocutaneous nerve and median nerve. So all the muscles which are supplied by this will be affected. But as we could appreciate that the palmar and rochii are being supplied by the ulnar nerve, so they will be spared. So again, this is just to test your concept of upper trunk and lower trunk injuries, that you should be very much clear that which of the trunk is giving which nerve, and you have to be very much clear about this supply. So regarding the musculocutaneous, we have the mnemonic BBC, and for the median nerve, apart from the flexor carpi ulnaris and the medial hub of the flexor digitorum profundus, all the muscles are being supplied by the median nerve. So take your time and revise rest of the concepts related to the brachial plexus, so that whenever you encounter this question in your exam, this diagram will pop up in your mind and you can clearly reach that which area you need to go to answer your specific question. So 28-year-old man got stabbed outside a nightclub in the upper arm. So the median nerve is transected, which muscle will demonstrate impaired function. So have in your mind the mnemonic LOAF. So any of these muscles which are of this LOAF mnemonic, you will be identifying that. So we have the abductor pollicis brevis. So revise from this diagram that which other muscles are being supplied by which nerve, because this is frequently tested area for the MRCS Part A exam. So here we have the palmaris brevis. As we know that this is present in the hypothenar, it is supplied by the ulnar nerve, and rochii are all being supplied by the ulnar nerve. We have the adductor pollicis, which is being supplied by the ulnar nerve. And we have the abductor pollicis longus, which is present on the extensor compartment. So it is supplied by the pin, that is the posterior interosseous nerve, which is the motor branch of the radial nerve. Then we have the abductor pollicis brevis, that is being supplied by the medial nerve. So you can also revise rest of the innervation for the lumbricals and hypothenar muscles as well. So what is the first branch of the axillary artery? So we have the superior thoracic artery as first branch from the axillary artery. Now what are the other parts? So first part of the axillary artery is going to give superior thoracic. Second part is going to give thoracoacromial as well as lateral thoracic. And the third part is going to give three branches. Number one is the subscapular. Then we have the anterior and posterior circumflex humeral vessels. So try to revise other concepts as well. So we have discussed that the hemorrhage or bleeding in the axillary area, the vessel that is going to be the answer is the thoracoacromial artery. Then anterior and posterior circumflex humeral arteries are important for the anastomosis around the neck of the humerus. They are making that anastomosis. Now, there's an important third concept that posterior humeral circumflex with the axillary nerve is related to the surgical neck of the humerus. So, this is how you revise or add all these concepts or all these MCQs in a single area, so that when you revise it, you can revise other aspect of the knowledge which is being tested in relationship to this area. So, next up we have a 62-year-old man who developed weakness in the arm, weakness of the elbow extension, and loss of sensation on the dorsal aspect, that is the posterior aspect of the first digit. So whenever we have extension, I have explained that close your eyes and reach the radial nerve. So that is going to be our answer. So the innervation of the radial nerve has a mnemonic that is best. It is supplying brachioradialis. It is supplying all the extensors, supinator, and the triceps. With reference to brachioradialis, it is one of the flexors of the elbow joint, but it is being supplied by the radial nerve. So that is an exception. So how many dorsal entrosia are there? There are 4 dorsal entrosia. So as you could appreciate from this diagram, they are taking their origin from these metacarpal bones. Now the first and the second are inserting on the radial side or the lateral side. So here you have the radial side or the lateral side of the the second and third proximal phalanx. So this is the proximal phalanx, and they're inserting on the radial aspect of this proximal phalanx, whereas the third and fourth, taking their origin from the associated metacarpals, are inserted on the ulnar side or the medial side of the respective proximal phalanx. But try to focus on this diagram. Alright, this can be very important to have a easy understanding rather than going through the text and getting confused.